I'll talk about single center experience with recurrent inguinal hernia, 1 year experience.
عايز ها؟ ما هو شام ده قلت ما جاش.
Can I start? Today I'm going to talk to you about our experience with the recurrent inguinal hernia repair in pediatric surgery. I'm a pediatric surgeon, and the age group that we deal with in our specialty is once the baby is born and even in utero and up to 12 years of age in Cairo University, in other countries up to 16, 17 years. Our cutoff limit here in Egypt is 12 years, so it's been very, very informative, like watching adult surgeons talking about inguinal hernias and the direct and indirect, and how common indirect hernia is in adult surgery and how common you're dealing with. In pediatric surgery, in our books, in our textbooks, it's always said indirect hernia is the hernia for pediatric surgeons. We do only herniotomy, there is no muscle repair. And this is what we are taught in the 6-year medical school. So literally, if you look up this picture, you've got the inferior epigastric vessels running down the anterior abdominal wall, and you've got here to the medial side is the side of the general surgeons. The direct hernia, this is how I was brought up to think. Direct hernia is the hernia of the adult surgeons. Our hernia is lateral to the inferior epigastric vessels through to the internal ring. So the internal ring is our area. The Hasselbach triangle is the adult surgeon's area. But when MIS was introduced in our center and we've been operating more and more laparoscopically, we just found out that no, this is more into this. We see more defects that needs more robust treatment than just a herniotomy. A muscle repair is needed. And our colleagues in Tanta University have been working on this, and they have come up with some interesting conclusions. So what I want to talk to you about is how we have managed our recurrent hernias laparoscopically, and what did we find out. So herniotomy per se is not just enough in those cases. We might need to do some sort of a muscle repair or even a mesh repair. Personally, I haven't come across a patient in pediatric age group who needed a mesh repair, but my colleagues have seen some and they needed mesh repair. The kind of repair that we do when a defect is present is called, I wouldn't say it's a Bassini repair. I mean, when we say this to my consultant, for instance, the head of the department, he would just laugh at us. There is no such thing as Bassini repair. But what we would do is the conjoint muscles is sutured to the iliopectineal tract, which is deep to the inguinal ligament. And this is the kind of repair. I know that I'm just going to show you towards the end, but as you can see here, there is a defect, and my colleagues in Tanta University, they have managed to put an algorithm for the repair of the hernia. So basically, if the patient has is a small internal ring defect is less than 4 millimeters, that means that there is no need for any kind of repair or even a herniotomy. If a 4 to 15 millimeter, we do a complete disconnection and herniotomy, the usual one. But if it's more than 2.5 centimeter or 25 millimeters, then we really need to consider this kind of muscle repair. And some patients who are born with certain conditions like ectopia vasica, bladder extrophy, they have a weakness in the anterior abdominal wall muscle, and this is the kind of repair that we do, and we did publish work on it. So, and just to get into the core of what I want to talk to you about, I looked into 17 the patients who presented to us with recurrent inguinal hernia over a period of 1 year. We had 17 patients with recurrent hernia presenting to us. 2 of those patients were excluded upon laparoscopic exploration, which shows how important laparoscopic exploration, the vision it provides to us, because those patients simply had nothing, a hydrocele, one of them had severe infection, so we didn't have to disturb the anatomy of the inguinal canal once more in order to operate. And 15 patients carried out recurrent hernia repair. 11 of them had laparoscopic hernia repair. The ones who had the laparoscopic hernia repair mostly were the ones presenting electively to our department. But the ones who came to the emergency, only 3 out of 7 had the privilege of the laparoscopic repair, which shows that the feasibility of laparoscopic or MIS in emergency department needs to be increased more, and we need to encourage more, to be encouraged more to do it laparoscopically. So we had in total 11 patients who had laparoscopic repair, 3 on emergency basis, and 8 had inguinal elective laparoscopic repair electively. So 5 patients of them had a herniotomy and muscle repair. Those were older patients, 3 to 9 years old. 4 of them were males, male infants, and 1 female. And 6 patients had a herniotomy. The age range, just pure herniotomy, no need for a muscle repair, and they were aged between 1 month and 1.8 years. So, and 4 of them were males and 2 of them were females, yet the females were like 6 years old. So this is also, I wanted to show you a picture of, I was worried that if I put a video, it will not work properly, so I just put a slide of pictures showing this is an irreducible hernia following a previous hernia repair done somewhere. I can't remember where exactly, but this hernia, there is one of our colleagues from Qatar here had presented his work. Yes, we can do that, and of course, if the hernia ring is very tight, we can extend it laterally. This is a very good idea in order to bring out the bowel. We are very careful when it comes to children with irreducible strangulated hernia. We have a very, very, very low threshold to convert to open surgery because of the ischemic bowel, but widening the ring is going to be a very good idea. We do it open, so why not do it laparoscopically? And then this defect is seen at the end. We take the medial arch fibers of the conjoint tendon to the thickened lower border, which I presume is posterior to the inguinal ligament. And I don't know why I knew there was something missing in my presentation. I figured out that it was this repair. But there is a video available online about laparoscopic repair of patients with bladder exstrophy by Heba Taher and my colleagues. You can find the full video of the repair that we are doing. So what I want to conclude, or the message I want to convey, we do learn a lot as a pediatric surgeon. This is one of the reasons why I'm very keen on attending conferences for adult surgeons. I do get a bigger perspective about what we are doing in pediatric surgery. I get more ideas. It's like I'm stealing ideas from you. And also the repair. We realize that there are more in common between us the more we do minimal invasive surgery, because of the superior vision that the laparoscopic approach provides for us. So minimal invasive surgery is a cornerstone in recurrent hernia. Minimal invasive surgery in general it's really worth investing in. It avoids negative exploration, as with the 2 cases which we have excluded even the presence of hernia. Neonates and infants and older females are less likely to need muscle repair, while older children are more likely. I've seen one of my colleagues here who was presenting who had a mesh repair for a patient who was 18 years old with an indirect hernia and had a mesh repair. So it seems that the older the child gets, the more likely he needs a muscle repair. And this is my contact details in case you're interested in doing any research work or common projects. you are welcome to contact me. Thank you.
Thank you, Professor Heba, and we could allow for 2 questions. Any question? Please.
Thank you for your nice presentation, Dr. Heba. I want to ask about the type of repair you do with absorbable suture. If you suture the muscular arch to the iliopubic tract, was absorbable or non-absorbable suture, and which type of non-absorbable or absorbable suture?
Thank you very much for this question, which is indeed very important. We use non-absorbable sutures. Some of my colleagues prefer the Prolene, which is, they think it's better and glides easily through the tissue. Others prefer the silk sutures. I personally use the either. And there is an AC bond as well, they use it.
I want to ask about the cases which diagnosed intraoperatively as it is hydrocele. If it is a communicating hydrocele, is laparoscopy has a role?
Yes. Actually, there is a study in Tanta University. They have got a prize somewhere in Germany for operating laparoscopically on patients with hydrocele. Yes, there is. I think Samah Shahata has got the papers.
Yes.
We can in the break we can ask him, or I can show you the publication. It's published in a very high impact journal.
The pneumoperitoneum in the infants, on 6 or less or more?
In infants, it depends on the region, but in infants it has to be low, about I would say 6, 7. As long as it and the flow has to be 1 mils per minute or so.
Any units laparoscopy is used in Kasrlani?
Yes.
one day.
But we use very small tools. We use 3 millimeter tools. We don't use and the camera. The working is 3, and the working port is 5. So max, that's the sizes that we use for infants and neonates.
5 millimeter?
5 work the camera, and the 3 for the working ports.
Why not the 3 millimeter port for the camera?
No, we use the camera is 5 to allow, because it's usually the camera is usually big, and we have to use it. It's in the umbilicus anyways.
The port site is closed 5 millimeter in infant. Board site closure is done?
Yes, 5 in the umbilicus, and the working is 3.
Closed at the end of operation?
Oh, of course. Yes, the skin, we usually close the skin.
The facial closure?
Yes. Sometimes if we use huge pores and there is a big defect, we use if not, because some of my colleagues prefer portless technique, we don't have to do that.
Thank you.
You're welcome.
Any other question? Thank you, Professor Heba, for